We're going to move right into Dr. Wolin now. If you've looked at his, many of you know him, but if you've looked at it, come on up, Ed, while I'm talking. It's okay. Go ahead. I'm just stalling until you get up there. But he's been everywhere. Yale, East Coast, West Coast, Midwest, North, South. He's one of the towering figures in this field, and we're just glad to have him. And he's going to talk about clinical trials. Ed?
Thank you. Okay, well, it's a great pleasure to be here and to talk to you about one of my passions, which is clinical trials in neuroendocrine tumors, systemic therapies of different kinds, and where we are and where we're going. First thing I'd like to tell you is that neuroendocrine tumors are relatively uncommon tumors. They're a little bit more common in prevalence than they are in incidence, as you heard from Dr. Kuntz, but they're still not nearly as common as things like breast cancer, prostate cancer, lung cancer, colon cancer, where you can do trials with thousands of patients and quickly get answers. 10 or 15 years ago, there was really nothing in the world literature on how to treat neuroendocrine cancers except for anecdotal case reports where doctors would write up an interesting patient, or small single institution series of limited numbers of patients treated in some way or other, and very difficult to evaluate the data properly and make decisions about what to do. Practically all decision making had to rely upon experience and judgment of oncologists who were treating this kind of disease, and there was not much in the way of rapid advance. However, at around that point, randomized clinical trials started. These are trials that took a tremendous amount of money, a tremendous amount of effort, and collaboration of many institutions throughout the United States and in many cases throughout the world in order that enough people can be treated on a clinical trial setting to allow determination of statistically significant and important results. As a result of these clinical trials, we've learned an enormous amount about how to take care of carcinoid tumors and neuroendocrine tumors of all sorts. And since this has all happened just in the last 10 or 15 years, I've been fortunate enough to be a major part of this, and virtually all the trials we'll be talking about have, Cedars-Sinai has been a major player in doing these trials. Many people in this room have been participating in clinical trials in the past or are currently on clinical trials now. And as all of you know, when anybody is offered a clinical trial, it's always for the benefit of patients as well as for potential benefit of the world. Because if a trial does not have the potential of being of benefit to the individual person who's participating, there'd be a real question about whether it would be ethical even to offer such a trial. So we try to make all clinical trials potentially of benefit to patients, and then the results are then generalizable and help other people. So that everything we do in treating neuroendocrine cancer stands on the shoulders of the previous clinical trials and allows treatment to get better and better and better. And it's really only because of these clinical trials that we have what we have today. So I wanted just to give you that little introduction. The other thing I wanted to tell you is that, as Dr. Kuntz pointed out in her talk, a multidisciplinary approach to management of these rare tumors is key because there are several aspects to care that need to be considered in an individual patient in trying to figure out what's better. In some cases, a clinical trial participation can represent one of the best options for care. In other cases, it wouldn't be appropriate at all. And it depends on the particular patient and the particular problems and the particular psychology and the particular disease features. We have at Cedars a multidisciplinary team that includes many different medical specialties. Medical oncology includes, of course, myself, but I should mention that there are 4 other medical oncologists at Cedars who also have a significant interest in neuroendocrine cancer. Dr. Andrew Handafar, who treats gastrointestinal and neuroendocrine cancer, Dr. Ronald Natali, who treats lung cancer and lung neuroendocrine cancer, and Drs. Monica and Alan Mita, who specialize in investigational drugs of diseases including neuroendocrine cancer. So we have a team. We also have an endocrinology group with a special interest in neuroendocrine cancer, spearheaded by Dr. Run Yu, co-director of the center, and radiation oncology, cardiology, cardiac surgery for dealing with carcinoid heart disease, specialized gastroenterology, including different types of endoscopy for identifying primary tumors and complications, pathologists who have a special expertise in neuroendocrine pathology, interventional radiology to do things like radiofrequency ablation, and various types of embolization of liver metastases, diagnostic radiology with sophisticated imaging, nuclear medicine involved in not only doing octreotide scans and gallium dotatate scans for diagnostic purposes, but also collaborations with nuclear medicine in radiopeptide therapy, so-called peptide receptor radiotherapy that we'll be speaking more about later, and surgery, which can include liver surgeons, surgical oncologists, thoracic surgeons, and multiple different surgical specialties. At Cedars, we have Nick Nissen and Dr. Steve Calhoun. Those are the primary liver surgeons, and Dr. Farron Amercy, who's been very much involved in surgical oncology issues, to name a few. Also, I just want to mention that the multidisciplinary team involved in figuring out what to do with patients includes not only doctors, but also other key individuals as well, including our oncology nurses, Arpi and Tina, our wonderful nurse practitioner, Hang Zhou, our research coordinator, Sandra, and the whole research team who works with her, pain management team, psychosocial team, dietitians, complementary medicine, even the medical secretaries who answer the telephone when distraught patients call and have to figure out how to triage the call, radiology techs, pharmacy registration, blood drawing, survivors program, scheduling, and I'm sure many others that I didn't have enough arms on this little cartoon to put on, but everybody is part of the action. So with that background, I'm going to give you a little idea about what's happening in clinical trials. First of all, chemotherapy in the usual sense usually does not work for neuroendocrine cancers. We'll talk about a few special exceptions like capecitabine plus temozolomide that Dr. Kuntz mentioned, but in general, most of the chemotherapies are targeted biologic agents. And what makes this particularly exciting right now are the following. There are lots of properties of neuroendocrine cells which make them a little bit different than normal cells and allow treatments to be targeted. And every one of these things that I'm talking about right now are potential targets for generations of clinical trials that are either ongoing or about to start. There's a unique chemical makeup of neuroendocrine cells that is making them ideal targets. They have increased numbers of blood vessels, as you saw earlier, and substances that stimulate blood vessel growth can make cancers grow faster, and things that inhibit blood vessel growth can actually make the cancers die and be starved out without enough oxygen and food. Cell membranes of neuroendocrine cancers have increases in tyrosine kinase growth factor receptors that allow certain drugs like sunitinib in pancreatic neuroendocrine cancer to attack the cancer cells selectively and kill them. There are genes involved in maintaining the malignant state that are overactive in neuroendocrine cancer. We'll be talking a little bit more about that later. Neuroendocrine cells have lost dependence on external stimuli to continue multiplying, and instead they generate internal signals and continue to divide. That makes cancers so-called immortal. They just keep dividing and dividing and dividing until the organism that they're growing in ends up dying if you don't stop this growth of cancer cells. So we're identifying the substances and the targets and the mechanisms of uncontrolled growth so we can specifically attack those in cancer cells. Neuroendocrine tumors don't respond to stop growing signals that make the cancer stop dividing, stop increasing, so we can attack those. In addition, there's a membrane that underlies cells. Cells are sort of adherent to a membrane, so they're not all floating around in the blood. They're actually adherent to a surface. That's called the matrix. And it turns out that when neuroendocrine cells don't stick properly to the matrix, it lets them float off and metastasize. So by dealing with the adhesion to the matrix, we could stop the metastatic process. And we could interfere at all of these different levels to stop the cancers from growing. In addition, there are defective enzymes necessary for cancer cells to die. And interestingly, normal cells in the body have an ability to die when they are no longer needed. Cancer cells don't have that. It's called apoptosis. And that mechanism in cancer cells can be dealt with to make the cancer cells die when you want them to. Neuroendocrine cells also have changes in their cell surface that help them escape immune destruction. And by working with that, it can make immune therapies possible, as Ron Hollander was alluding to earlier. There are also mutations making them resistant to treatment with available types of chemotherapy and biologics, and as we identify those, we could attack the mechanisms of resistance. Also, briefly mentioned by Dr. Kuntz was molecular profiling. Tumor specimens can be removed at surgery, and they can be sent for a genomic analysis, and you can actually determine what the mutations are within the cancer, and the results could potentially be used in guiding chemotherapy, targeting biologic therapy, and sometimes even be a prognostic importance as well. 4 driver mutations in pancreatic neuroendocrine tumors were mentioned both by Dr. Kuntz and also by Ron Hollander, with research that was supported by the Caring for Carcinoid Foundation. Really seminal research that was done primarily in Johns Hopkins and several university centers, and has stimulated a whole generation of really important research in the molecular biology of neuroendocrine tumor cells and how to develop specific therapies that attack them. So stay tuned. The era of molecular profiling and personalized medicine is already here. Might be in its infancy, but it's still here. However, keep in mind also that because we're dealing with such a new era of technology, there still are problems. We have to be careful that genomic analysis can give a lot of information, but we don't necessarily have treatments that are effective for all the things that we find. We don't have assays that are necessarily adequately validated. Sometimes, as a result, incorrect patients can be selected for treatment. These treatments sometimes cost a few $1,000s that insurance may or may not pay. Sometimes you have to screen a large number of patients before you find one that is able to be effectively treated. And in addition, as tumors live in the body, they develop additional mutations. So a mutation that you find at the time of initial diagnosis may not be present 5 years later when you have a growing metastasis. And the question is, when is it ethical and when is it safe to do additional biopsies and to do additional analyses to have up-to-date molecular information? One of the exciting things that's happening in this field is the ability to get molecular information about tumor cells or tumor DNA out of the blood. And I think stay tuned. That's going to be something that's going to become important over the next few years and may obviate the need for doing invasive biopsies to figure out where we stand and what to do for treatment. Okay, next thing I'd like to talk about some of the specific targeted therapies that we have for neuroendocrine cancer and the clinical trials that we have. I'll give you a brief background about somatostatin, since Dr. Kuntz already talked about that. But this is a peptide hormone that stops neuroendocrine cancer cell growth and stops neuroendocrine cancer hormone secretion as well. The action of somatostatin is mediated by these somatostatin receptors on the surface. Do you remember the type 2 receptor that somatostatin sticks to? But somatostatin has a very short half-life. It lasts in the body only for 2 or 3 minutes, and that doesn't make it a very practical drug. So modifications of somatostatin have been made that we call somatostatin analogs, and these modifications can be present for hours or for weeks and can have a long period of effective action. They make good therapies. The one that is most commonly used is known as octreotide, brand Sandostatin, and octreotide LAR. These are FDA approved at the present time for carcinoid syndrome. There really are no drugs that have ever been approved by the FDA for any of the well-differentiated neuroendocrine tumors we're talking about today, except for sunitinib, everolimus, and streptozotocin for pancreatic neuroendocrine cancers. Every other thing that you're hearing about today from all the speakers for treatment of neuroendocrine cancer is either investigational or off-label. Unfortunately, we don't have the more approvals yet. Hopefully more will be coming shortly as the clinical trials are showing such exciting data. This is a cartoon of somatostatin. Human somatostatin, you see on the right here, has the part that sticks to the cell is in purple, okay? This is what we call the binding site. This is the part that actually sticks. The rest of it holds the whole molecule together, but the part that sticks is right here. The somatostatin receptor analog octreotide has an almost identical binding site. There's one amino acid right here that has a teeny difference, but it's very similar. But just by making this little modification in the rest, it allows it to have a 90-minute life. And by making other formulations, you can have injections once every 4 weeks. The PROMID study using octreotide versus placebo, we just saw with Dr. Kuntz, demonstrating that octreotide does indeed have anti-cancer properties and can be used as an anti-cancer drug. Lanreotide is a new somatostatin analog, which is a subcutaneous preparation, can be given as a subcutaneous injection once every 4 weeks, and is potentially able to give higher doses in a small volume, can be tolerated by people who have either very thin or very fat rear ends, because otherwise you may end up with an injection that would be too deep in the case of a thin person, or one that ends up in fat instead of in muscle in the case of somebody who's obese. So it has that advantage as well. It also has very exciting anti-cancer effects. The Clarinet trial, which is a randomized trial of lanreotide versus placebo, has been done in centers around the world. Cedars-Sinai was one of the major centers for doing this trial, and the results are fantastic. The latest update, the progression-free survival, the amount of time it took until cancer grew, was 33 months. In the original publication, it hadn't been reached yet, but now we know it's 33 months. And in the placebo arm, progression-free survival was 18 months. It basically doubled the amount of time the cancer was able to be kept under control, which is fantastic, and I would hope the FDA will be considering this very shortly. The lanreotide proved to be effective in all types of well-differentiated neuroendocrine tumors. It didn't matter if they were grade 1 or grade 2. It didn't really matter if they came from the pancreas or they came from the intestines or anywhere else. And it also seemed to work if you had lots of metastatic disease in your body or only a little, in all these different populations. So even though octreotide and lanreotide have very few side effects, you don't want to minimize the effect they have as an anti-cancer drug, because it's often possible to keep cancers under control for many years with quality of life. And when you see median progression-free survival 33 months, that doesn't mean that's everybody. That's the average. Somebody's cancer might progress in 3 weeks, and somebody's cancer might progress in 15 years, and you average it all together. But in some fortunate individuals, these drugs could last for many, many years with excellent quality of life. Okay, another somatostatin analog, which we've been very much involved in developing, is known as pizeriotide. Pizeriotide, unlike octreotide, sticks quite tightly to somatostatin receptor subtypes 1, 2, 3, and 5. So instead of sticking almost entirely to type 2, it binds to more places on the cell membrane and can potentially work in situations where octreotide is unable to. The side effects are almost identical to octreotide. It's an injection in the rear once every 4 weeks. It causes more problems with blood sugar elevation than octreotide does, although that can be a side effect of octreotide as well. In a phase 2 trial, carcinoid syndrome was able to be improved when people were not able to be controlled on octreotide. In a large randomized trial known as C2303. This is a very large trial comparing pizeriotide to octreotide. The demonstrated benefit in controlling syndrome was not able to be seen, although diarrhea and flushing were able to be controlled in both groups. However, the people that were getting pizeriotide looked like they had a longer period of cancer control, which is very, very exciting, and I'm sure will lead to more trials of pizeriotide in the near future. The next use of octreotide I wanted to talk to you about was using octreotide as a means of delivering a lethal radiation into a cancer cell. If you look over here, this is a molecule of a somatostatin analog, like I was just showing you with somatostatin and somatostatin analogs with a binding site and another place. The only difference is in this particular cartoon, the binding site is blue instead of pink. They reverse the colors, but blue is where the action is. But then this molecule is attached to a chelating agent. A chelating agent is able to hold a heavy metal inside of it, and it's attached permanently to this octreotide. So by doing that, we can put a radioactive molecule into this little cage, and it gets stuck. In this case, it's lutetium-177. Lutetium-177 is a radioactive isotope which shoots out a beta particle that goes for 2 millimeters. Okay? So you can deliver this to a cancer cell. It can nuke the cancer cell and can nuke the surrounding area, maybe a 1/16 of an inch, and that's about it. So you have very little collateral damage. It's a very, very highly targeted way of delivering radiation into tumors. In addition, as you'll be hearing in the next talk, you could put gallium-68 into this little cage with exactly the same molecule, and gallium-68 shoots out gamma rays that can be used for imaging, and by doing that, and sorry, not gamma rays, but it's a positron emitter, and you can get a PET scan with gallium-68 inside this little cage, and you'll be hearing a whole lot more about that very soon. Okay. The data from Europe on using this type of therapy with lutetium-177 labeled octreotide, one treatment intravenously every 4 weeks, 200 millicurie dose, standardized dose. They evaluated toxicity in 504 patients and efficacy in 310. Like with the other drugs that we've been talking about, most people don't have a big tumor shrinkage, but it can control cancer often for a prolonged period of time. 28% of patients had a major tumor shrink, 16% a more minor tumor shrinkage, but still shrunk. But most importantly, in these patients who largely had been treated extensively with other things in the past, it was able to prevent any cancer growth for an average of 40 months, which is a long period of cancer control just based on these 4 treatments of intravenous lutetium-177 labeled octreotide. And this is what happened in one of the patients that did have a major shrink. Again, it's not a complete shrinkage, but it's sure a pretty dramatic one. This patient here this is a CAT scan from the same patient right here, and every one of these dark things is a cancer. And look at the huge improvement that happened after 4 intravenous infusions of lutetium-177 octreotate, technically. Okay, so based on this data, a large multi-center trial is being done in the United States and Europe, trying to determine exactly what is the role of this treatment in patients with metastatic carcinoid tumor. And it's a study which is ongoing in the western half of the United States. This trial is being conducted at Cedars-Sinai and also at Stanford University. There are several other centers around the country where it is being done as well, and several centers in Europe. Patients are given exactly the same dose of radioactive isotope that they were receiving in the European experience, 200 millicuries approximately every 8 weeks. To be eligible for this trial, patients need to have a tumor which is of so-called midgut origin, meaning it started in the small intestine or the nearby structures like appendix and the nearby small and large intestine. The proliferative rate has to be, by Ki-67, has to be not more than 20%, meaning it's grade 1 or grade 2, so-called well-differentiated neuroendocrine tumor. Patients have to have progressive disease while taking octreotide. They have to be an adult population more than 18 years old. And they have to have a positive octreotide scan, although for this purpose, it doesn't need to be very strongly positive. It just needs to be positive with activity similar to activity in liver. And you have to be strong enough and functional enough that you can have an investigational trial. For patients that are on this trial, it's a randomization between the radioactive octreotide and a double dose of regular octreotide. So it's octreotide 60 milligrams every 4 months, every 4 weeks versus a radioactive type of octreotide and normal dose of regular octreotide. Okay, half the people get the radioactivity, half the people don't. To give you just a brief survey of some of the trials that have been going on recently and are ongoing with neuroendocrine tumors that are outside the pancreas. I'm going to use the term carcinoid for convenience, well, even though we have been hearing that that's not the most current term being used by pathologists right now, but it just makes it easy to call the ones in the pancreas neuroendocrine and the ones outside the pancreas carcinoid. I'm going to say that for right now. So everolimus and carcinoid, there was a trial called RADIANT-2, everolimus plus octreotide. It looked like there was a 5-month advantage in holding the cancer back from growing when people got the combination, when they got everolimus. It didn't reach statistical significance by the criteria that was initially set up. So another trial was performed known as RADIANT-4. RADIANT-4 is a trial of everolimus versus placebo. 2 people get everolimus, 1 person gets placebo. And that trial has been closed to accrual, meaning all patients that can be enrolled in that trial have already been enrolled. And I would hope that in the near future we're going to be seeing results from that trial, and we're all anxiously awaiting. If it turns out to be positive, I think it'll offer us another wonderful drug for carcinoid tumors, being an oral and highly targeted therapy. We've also been investigating at Cedars, again, one of several centers in the country doing this, a drug called CC223, which is a next generation mTOR inhibitor drug like everolimus. It's one that has additional action and inhibits 2 enzymes instead of 1 enzyme, and the results are looking very hopeful, and we are awaiting the results of that and see where that is going to go as well. But everolimus is a targeted biologic drug, a very, very interesting drug. It's actually like an antibiotic that's made by a fungus that was originally found from a fungus growing in the soil of the Easter Islands where the giant heads are located. And that drug turned out to be a unique antibiotic that has anti-cancer properties. And all of these drugs are sort of derivatives of that antibiotic. So the CC223 data is looking very promising, and we're going to, I suspect, see more of that very shortly. Next thing I want to talk about a little bit are anti-angiogenic drugs. Again, you heard from Dr. Kuntz, and also I spoke a little bit earlier about the importance of blood vessel prominence in neuroendocrine cancers and the importance of blood vessels in keeping neuroendocrine cancers going. Bevacizumab is a monoclonal antibody to vascular endothelial growth factor known as VEGF, and it inhibits the growth of tumor blood vessels. It can cause toxicity, but usually toxicities are mild. Serious toxicities, including major blood clots or bleeding, or problems with wound healing, can happen. It has to be used carefully, but most people tolerate it well. In a trial that was a small trial done by Dr. Kuhlke at Dana-Farber, there was a 24% response rate in neuroendocrine tumors, led to a very large trial through the Southwest Cooperative Oncology Group. Again, we were doing this in a big way at Cedars-Sinai, and the results of that are still not published yet, but both the people getting bevacizumab, which is the anti-angiogenic, and the other group of patients receiving interferon alpha are both doing very well at this time. A new trial of another type of anti-angiogenic known as pazopanib is being made available now through the cooperative group mechanism. We have that available here, and it's available at multiple centers in the country using another type of oral so-called tyrosine kinase inhibitor. It's a targeted pill that stops the growth of blood vessels by targeting even more targets and targeting them a little differently than bevacizumab. It's looking like a very promising drug in neuroendocrine cancer, and we have to see the results. This is the trial, which is ongoing now, pazopanib versus placebo. Anybody who gets placebo, if they progress even after 3 months, they can switch over and have active drug. So half the people get active drug on day 1, half the people get active drug when they need it. So for these slow-growing tumors, this seems to be a very excellent and ethical trial design. Another drug I wanted to mention is a symptom management drug that I think is turning out to be quite important in carcinoid syndrome. This is the diarrhea, flushing, and other complications that you get from certain individuals with carcinoid tumor, again, which Dr. Kuntz talked about in detail. There is a drug called telotrestat atiprate, which is an oral medication that drastically stops serotonin production. It inhibits the enzyme that is needed to make serotonin, and serotonin blood levels become much lower, and it can potentially cause dramatic improvements in diarrhea and flushing. Toxicity for most people is mild in an oral formulation, but most importantly, it does not cross the blood-brain barrier, and as a result does not lower serotonin levels in the brain. Because if you lower serotonin levels in the brain, you get serious depression and other psychiatric problems, and then we have a panic call to Dr. Walcott. So fortunately, that is not happening with this drug. So again, we have to wait and see what's happening. There's a phase 3 trial that is continuing to accrue and is almost finished accruing, and then we have to once again wait on the results, but I want to let you know what's out there. Pancreatic neuroendocrine tumors are uniquely sensitive to biologics, chemotherapy, and other types of anti-cancer treatments. And for that reason, studies of pancreatic neuroendocrine tumors tend to be segregated out separately. And for most clinical trials that are currently happening in the United States, pancreatic neuroendocrine tumor trials are separate. Pancreatic neuroendocrine cancer is the one kind of neuroendocrine cancer that seems to be uniquely sensitive to chemotherapy. The combination of streptozotocin, doxorubicin, and 5-FU seemed to result in a tumor shrinkage of 39% when the data was reanalyzed by current criteria for response. It's a very respectable anti-tumor effect. Streptozotocin is not used very much these days because of the potential for injury to the kidneys and other problems that it can cause. So we tend to use other types of chemotherapy like temozolomide with or without capecitabine, but I think it still is something to remember that we have an active drug there. Temozolomide and capecitabine, as Dr. Kuntz told you, is an active program, and as a result, a randomized trial that Dr. Kuntz actually spearheaded the development of is now ongoing through the cooperative group system and is available in multiple centers in the country, including Cedars, temozolomide versus temozolomide and capecitabine together for pancreatic neuroendocrine tumors. All right. All of the cancer trials, by the way, that I've ever been talking about so far in this talk have been for well-differentiated neuroendocrine tumors, which are defined as having a Ki-67 proliferative rate of not more than 20%. However, there's more and more data coming out that there are patients with Ki-67 between 21 and 55% that actually can respond to similar medications, but for sort of a homogeneous patient population in clinical trials, they're not being included in these trials, but there are other trials that are now being written for people in this population. And there are also patients with high-grade neuroendocrine tumors that are exceedingly aggressive, that are resembling small cell carcinoma of the lung. And again, there are clinical trials for that population that are ongoing. The RADIANT-3 trial, this is the same slide that Dr. Kuntz showed you. The people that got everolimus had a major progression, a major advantage in control of cancer. They went for an average of 11.4 months versus 5.4 months in people who had placebo when they got everolimus. So this was really a very valuable thing. Again, the people that got placebo in this particular trial were able to cross over and then get real everolimus. So that trial was built in such a way. Okay, so this drug is now FDA approved. It's an oral pill. It's well tolerated. Toxicity is good, is acceptable. And we have to now wait on the next generation of clinical trials that are being done with everolimus. They're trials of everolimus in combination with pasireotide. They're combinations of everolimus in combination with other drugs. And there are trials of new kinds of mTOR inhibitors that are potentially next generation after everolimus, and we have to see the results of all of these things. Sunitinib is the drug in pancreatic neuroendocrine tumors you heard about a little bit earlier from Dr. Kuntz, which has recently been approved by the FDA in treating pancreatic neuroendocrine tumors. It is a pill which has anti-angiogenic properties in addition to some other properties from blocking that tyrosine kinase on the membrane. And it's also looking like the results are as good as everolimus results in more than doubling the progression-free survival, in doubling the time the cancer can remain stable and free of growth. So we have lots and lots of new trials. The time is limited, but I just wanted to introduce you to the whole field of clinical trials for neuroendocrine cancer and some idea of where we are and where we're going. And in the question period, I'm sure we have time for other questions. But thank you for allowing me to speak with you today.